Good afternoon, and thank you for joining us for today's webinar, where we're going to cover how to select an E&M level of service. My name is Jennifer Kastner-Thomas, and I'm the Code Director here at SENTA, and I'm thrilled to have you join us for today's session. Before we dive into the contents, let's quickly go over a few housekeeping items. We kindly ask that all participants mute your phones and your computers to reduce background noise. Also, to ensure that we're able to cover all material during our designated time frame, we will be taking questions related to the presentation at the end of the session. And I'm sure there's going to be some questions. We may run out of time. If that's the case, reach out to me. Also, the information that we're covering today is current as of today, and it may change as new information or clarifications released by CMS, the AMA, or any of the Medicare administrative contractors. And any questions related to this presentation could be directed to me, Jennifer Kastner-Thomas, at jennifer.kastner@sentapartners.com. Today's agenda will mainly focus on how to select an E&M service. However, first, we will discuss a couple of key topics that are essential for medical necessity compliance. We're going to be discussing how to capture medical necessity within the documentation, as well as clinical and ICD-10 documentation guidelines. And finally, we'll be discussing how to select an E&M level of service based on the newest documentation guidelines by using either total time or medical decision-making, also referred to as MDM. First and foremost, we're going to discuss the concept of medical necessity, which should be the primary requirement guiding any medical service. According to the Medicare guidelines, medical necessity stands as the overarching criteria for payment, alongside the specific requirements outlined by a CPT code. Medically necessary services and supplies are those deemed appropriate and essential for the diagnosis or treatment of an illness, injury, disease, or symptoms. They must adhere to the standards of good medical practice, be clinically appropriate, and not primarily serve the convenience of either the patient or the healthcare provider. The documentation should support the justification of the care and services ordered or provided to the patient. Your documentation should essentially narrate the story of each patient encounter. It's critical that every detail support why the patient's being seen or why a particular procedure is being performed. Every aspect must align with the principle of medical necessity. Therefore, when documenting for medical necessity, ensure that your documentation is clear, accurate, and comprehensive. It should accurately reflect the medical needs of the patient for that specific encounter and support the severity of their signs and symptoms. Additionally, ensure that your documentation captures the following key elements, starting with the patient identification. This consists of indicating if the patient is new or established. A general auditor rule of thumb is that it's assumed to be an established patient unless otherwise stated. So definitely the documentation should indicate if it's a new patient. And a new patient is one that you nor anyone in your practice has seen within the past 3 years. Next, it should indicate the encounter reason. What's the purpose of the visit, along with the relevant historical data, the physical exam findings, and previous test results. Next, the assessment and diagnosis. This should include your clinical impression, assessment, and accurate diagnosis. Each condition that you are addressing should have a clear status and plan of care. And any conditions that are simply listed in the problem list or the assessment and plan portion of the note without a clear status or plan of care or how it affects your medical decision-making for that encounter will not be considered as truly addressed. The note should also reflect the medical plan. It should outline the planned course of care and specify when the patient should return for follow-up. Also, identify any relevant health risk factors that may impact the patient's condition. The documentation should also reflect the patient's progress, their response to treatment, and any treatment modifications, as well as any orders or tests or procedures or referrals. They should all be well documented in the progress note and the medical necessity for them. So why are they being ordered and referred? And then finally, to conclude the note, it should reflect the billing and rendering provider signature and the date of signature. Right. Complete and detailed documentation is essential for accurate diagnosis coding. Providers should document the condition to the highest level of specificity and select the ICD-10 code with that level of specificity. This includes laterality. When it comes to denials, this is one of our most common denials. We're finding that the documentation supports the location. However, many providers are selecting an ICD-10 code for an unspecified side. For example, otitis media unspecified is being used instead of the code indicating left, right, or bilateral. We're asking all providers to be extra cautious of the code you're using and to try to avoid the use of unspecified codes when possible. When it comes to laterality, this is something that's always known at the time of the visit. When it comes to which diagnosis to bill, you should code the condition that is relevant based on the assessment. In the absence of a confirmed condition, such as cases where you're actively working them up and have ordered diagnostic studies for evaluation, you should code the signs and symptoms. However, do not code the signs and symptoms when a confirmed diagnosis has been established. For example, ear pain with otitis media. That is part of otitis media, so you would not code both of those. And finally, the only condition that can be counted towards your medical decision-making are those that meet the acronym MEET. So monitored, evaluated, assessed, and treated. So only those conditions that reflect monitor, evaluation, assessed, and treated could technically be counted toward the level of service. Now on to how to select an E&M level service. But first, what is an E&M service? An evaluation and management service refers to the activities performed by a healthcare provider in assessing or managing a patient's health condition. These services commonly involve consultations, follow-up visits, or any other interaction where the provider evaluates the patient's health or addresses a medical concern. E&M services are categorized under CPT codes ranging from 99202 to 99499 and are among the most frequently provided by physicians and other practitioners. So now we're going to go into the steps of how to select a level service. Our first option to use for selecting a level service is by using time. So you as a provider, you could choose a level service by either using total time or medical decision-making. Prior to 2021, we were only able to use time if the visit was dominated by counseling and/or coordination of care. And this has changed with the most recent updates, and we can now use time anytime as long as we only count qualifying activities and follow the guidelines, which I'm about to cover. This slide shows the different requirements by level of service depending on if you're using time or medical decision-making. Some providers lean toward using time because it's the easiest way to figure out the level of service. However, I find it more of using medical decision-making as more of a financially advantageous unless the visit is lengthy. And if that's the case, time is usually the way to go. For example, for a 99213, right there, you have to have at least 20 minutes or a low medical decision-making. Many visits relate to acute condition, which often, not always, but often is at a minimum a level 3. So that's why I usually tend to use medical decision making, especially for acute conditions, because like, like I mentioned, if you're using time, you would have to have 20 minutes if you're billing that level 3. But you'll see here in a minute, you don't have to spend that much time with them if you use medical decision making. Also, I noticed it cut it off here. At the bottom is a level 5, and for a 99215, you must either spend 40 minutes or have a high medical decision making. When using time, it's important to know that we could only count time that is spent providing qualifying activities on the same day that you're seeing the patient. This means if you are doing any of the qualifying activities that I'm about to cover, that you can't count this time unless it's being performed on the same day that you are seeing the patients. One of the most common things I see is maybe the provider the day before is preparing to see the patient. Unfortunately, the way the rules are currently set, we would not be able to count that prep time the day before because it didn't happen on the same day that you saw the patient. I hope to see this be an area that they relax in the future. I do see steps. The fact that we're able to count all these other qualifying activities that I'm about to cover, it shows that they're moving forward to some degree, but hopefully in the future they'll relax it where maybe there's a window of 24 hours before and after. But for now, we can only count the time for qualifying activities that are being performed on the same day that you're seeing the patient. This slide reflects all of the qualifying activities that can be counted towards time, which includes preparing to see the patient, obtaining and reviewing the patient history, and performing a medically appropriate examination, counseling and educating the patient, family, or caregiver, ordering medications, tests, or procedures, referrals, and communicating with other healthcare professionals. I want to point out this is performed by the provider, not by ancillary staff members. It has to be performed by the provider. Documenting clinical information in the EHR. But remember, if you're documenting the next day, you can't count that time. It has to be, if you're documenting on the same day you're seeing the patient, you could count that time. Independent interpretation of results and communicating the results to the patient, family, or caregiver. And last, care coordination. A few pointers when using time: the documentation must reflect the exact time. Do not round or give a time range. The note must reflect a summary of what the time was spent, or the time spent was associated with. So in other words, they want to see an itemization of how this time was spent. And this is to confirm that time is only being counted for qualifying activities. And lastly, do not count your time associated with other billable services. So the reason for that is when you're performing another service, there's a unique CPT code for that unique service, and you're already being reimbursed for your time with that unique CPT code. For example, if there's a minor procedure being performed on the same day and there's justification to bill an E&M on the same day, and you're wanting to use time, you cannot use the time that's
No, he forgot it.
Okay, can you please mute your phones, please, or your computers? Because we could hear someone. All right. So do not count your time associated with other billable services, because your time is already being reimbursed for that time when you bill that unique CPT code. All right, so we just covered time. I covered that first because it's the easier of the two. Now we're looking at medical decision making. So again, providers have a choice. They could choose a level of service based on time, which we just covered. And now we're putting our attention to the medical decision making. This slide reflects the medical decision making table that should be used when selecting a level of service based on medical decision making criteria. This table serves as a guide to ensure accurate coding and billing practices are aligned with the complexity of the patient encounter. I understand there's a lot of information on this slide, but I'm going to break it down further on the upcoming slides. But first, I want to point out that this table is the same for all specialties and for all places of services. So for office, hospital setting, outpatient hospital, it applies, it's the same, the table is the same regardless of the setting. This particular table has been customized where I added the office visits. So this I made particular and specific to office visit codes, and I will be sending these to you guys. So I have one for hospital, office, ER, depending on what setting the service is being provided in, and I will share those with you following today's session. But again, when it comes down to it, the actual table is the same regardless. So as I mentioned, I customized this. I added the codes, and starting with, you'll notice here, the very first column indicates the CPT codes that I listed. The top one's for new patient, the bottom one is for established patients. And again, this is just for easy reference, and I will send them to you. The second column, this is a level of medical decision making. You'll find that there are 4 levels of MDM. There's straightforward, there's low, there's moderate, and there's high. Now let's focus on the next 3 columns. These next 3 columns are the main columns here. These columns represent the 3 elements that actually define medical decision making. The first column is the number, complexity of problems addressed. The middle column is the data reviewed or analyzed. at the time of the encounter. And finally, there's the risk of patient management. In order to bill for any level of medical decision-making, you must meet or exceed the requirements for that level in at least 2 out of the 3 columns. So what does that mean? That means that for me to get a moderate medical decision-making, level 4, I would have to have a moderate or higher in 2 out of 3 of these columns, okay? So I may have a low here, a moderate here, and a high in the risk. I can't bill high because I don't have one more high. So there has to be, you must meet or exceed 2 of the 3 columns in order to designate it as low, moderate, or high. And I'll explain that all to you here in a minute. All right, so we'll dive into the first column, which represents the number of complexity of problems addressed. A problem in this context refers to a disease, a condition, illness, injury, symptom, sign, finding, complaint, or any other matter addressed during the encounter, whether or not a diagnosis is established at that time. It's important to know that a drug is considered addressed when it's evaluated and treated during the encounter. Multiple new or established conditions may be addressed simultaneously, impacting the complexity of the medical decision-making. However, symptoms related to a specific diagnosis are not considered a unique condition. Example, ear pain and otitis media. We're only going to count otitis media. We're not going to also consider ear pain a condition because it's associated with the primary condition of otitis media. And just a reminder, we can only count the conditions that are indicated as being addressed and that have a plan of care. Simply listing the condition without a plan of care will disallow us from being able to count that condition toward the medical decision making. All right, so starting at the top, straightforward. This is defined as a self-limited or minor problem. These are conditions that can resolve on their own, typically without medical intervention. And the AMA has defined this as a problem that runs a definite and prescribed course and transient in nature, is not likely to permanently alter health status. This could be for your conditions, like maybe they had a really bad ear infection and then they come back and it's completely resolved. It's no longer an active problem, so it could, that's an example that could be straightforward. Straightforward is associated with your level 2s, and when you look at the mix, typically there's not going to be as many level 2s versus the other like level 3s and 4s sprinkled with some level 5s. That wouldn't be uncommon. So if you're using a lot of level 2s, we need to have a discussion and make sure that you are giving yourself the true credit that you should be giving yourself when it comes to medical decision making. All right, so now moving on to low. Low, this could be 2 or more self-limited or minor problems, or it could be a stable chronic illness. So what is a chronic illness? They have defined a chronic illness as a condition that's expected to have a duration of at least a year or until death, or the patient has had it for, at least a year. It used to be 3 months or more, but now they have, with the newer recent guidelines, they have stated that's what the definition of chronic is. Stable, for the purpose of categorizing medical decision-making, is defined by the specific treatment goals for an individual patient. A patient that's not at their treatment goal is not stable. That's the takeaway I want you to take with that. If they're not at their treatment goal, then they're not going to be stable. Also under low is an acute uncomplicated illness or injury. These have a low risk of morbidity and little or no risk of mortality without treatment. This category involves self-limited or minor problems that are not resolving. An example of an acute uncomplicated illness includes your otitis media and an acute case of allergic rhinitis. I want to point out that general symptoms such as fever, body ache, or fatigue also fall within this category. However, they're often confused with acute illness with systemic symptoms under moderate. So I'm talking about this acute uncomplicated illness. A lot of times it gets confused with acute illness with systemic symptoms, and because providers are like, well, they have a fever, they have body aches, based on the AMA guidelines, General symptoms such as fever, body ache, or fatigue does not classify it as defined as systemic symptoms. So if that's the case, then it really is more of an acute, uncomplicated illness or injury. Next, we have stable acute illness, which would be a follow-up visit from an acute condition that is now considered stable. And then there's also, now moving on to moderate, there's this also acute uncomplicated illness or injury requiring hospital, inpatient, or observation level care. I'm going to tell you, I don't know an auditor that has used this, because if someone's sick enough to where they're going to have inpatient or observation level care, they're usually either having an exacerbation of something, or systemic symptoms, or severe exacerbation. There's something usually going on. So I'm going to, in the years that these rules have been released, I have not ever, used that. So, and I don't know an auditor that has. So, just want to point that out, because if you really feel like your patient is having an exacerbation and stuff like that, I would not use that for low. All right, so now moving under moderate. Moderate's your level 4s. Chronic illness with mild exacerbation, progression, or side effects of treatment, which is a chronic illness that is acutely worsening, poorly controlled, or progressing. In other words, a condition not at goal. Also under moderate, we have 2 or more stable chronic illnesses. We also have we have undiagnosed new problem with uncertain prognosis. This is likely to result in a high risk of morbidity without treatment. It's important for physicians to document any further workup needed in order to diagnose the patient, such as the biopsy or of a nodule. That just shows there's some workup that's being performed. And yeah, and it's undiagnosed at that time. Also, acute illness with systemic symptoms, I've also talked about this. They classify this as high risk of morbidity without treatment. As previously noted, those general symptoms such as fever, body aches, or fatigue, and a minor illness are not considered here as an acute illness with systemic symptoms. An example here would be otitis media with cellulitis. Next, under there, we have an acute complicated injury, and this is relevant when there's a need to evaluate body systems that are not related to the injury, and it's extensive injury, or there are multiple treatment options. Now moving to high, we have a chronic illness with severe exacerbation, progression, or side effects of treatment. These problems have a significant risk of morbidity and may require escalation of level of care. I want to point out that there's similar verbiage here as moderate, 1 or more chronic illness with mild exacerbation, and highs with severe exacerbation. And the reason why I point this out is outside reviewers and coders and auditors, we could usually tell if there's an exacerbation with a condition because of the complaint the patient's having, between reading the details in the assessment and plan, but also in the history of present illness and review of systems and the treatment plan. We're usually able to tell when something's not at goal because there's usually some medication that's being adjusted or some additional workup. But where I'm going with that is we're not clinicians and we're not able to diagnose. So when it comes to severe exacerbations, I recommend that providers use the verbiage severe when they feel like someone's in a severe exacerbation of something. Because again, we're not clinicians and we're not able to come to that judgment. So, and to prevent any scrutiny or having any gray areas, to prevent that discussion from even occurring, the takeaway is when you feel like something's severe exacerbation, use the word severe. Also under high, we have acute or chronic illness or injury that poses a threat to life or bodily function. These conditions have a severe exacerbation and or progression of side effects of treatment at the time of the visit, and also pose a threat to life or bodily function in the near term without treatment. All right, so that concluded our first column. Now we're going to put our attention to the second column of the medical decision making, and that is the amount of complexity of data to be reviewed and analyzed. And from an auditor perspective, a little Cliff Note version is sometimes I use the data column as more of a tiebreaker column, because if we're getting if basically the first and last column are the same, like a moderate and a moderate, then it doesn't really matter like this column what it's going to, pull to. So I usually, this is usually the tiebreaker column, but I also find with specialists, this level of information sometimes is being performed, but it's not captured in the documentation. So we'll go over this the categories within this element. All right. Before I go into this, though, I do want to go into details of this section. I want to point out that the code and guidelines state that any service for which the professional component is separately reported by the physician or other qualified healthcare professional reporting the E&M service, that we can't count these particular tests toward the data element. We can't give them credit for ordered, reviewed, analyzed, independently interpreted, when it comes to determine the level of medical decision making. So what does that mean? This means that when ordering tests such as CAT scans, VNGs, audiology tests, if we are also, or you are also billing for these unique tests, and because they have a professional component associated with it, we cannot count the order review, we can't count it toward the MDM. AMA and CMS considers it double dipping if you're billing for these services as well as counting them toward the medical decision-making component. And there are some like unique components, like some tests that are kind of don't apply, like your strep test, flu test. Those don't have a professional component. And when I say don't have a professional component to it, meaning we can't take that code and break it up and bill a professional and technical component, and there's a global code. And also those tests are results only. So those are a little bit different. So I have a feeling that this is probably going to stir up some conversation. Happy to have that discussion offline and talk with your group, whatever it may be. But this also goes for the audiology tests performed within your organization. Even though they are performed by an audiologist and not you, this cannot be counted toward MDM because it goes in line with what I just mentioned. Even though these services are often billed out under the audiologist and not you, you are all an extension of each other, and there's a professional component associated with it that's already being reimbursed. Again, I'm happy to take this offline because this is one of those areas a lot of people don't realize. In fact, it was when I first learned these new rules, this is a common area that auditors get stuck on because it's confusing. If it's confusing for you, it's confusing for us. So we really had to learn these guidelines, and it boils down to if it's a CPT code that we bill for. Now, if you're ordering that CAT scan and it's not being billed out for us, maybe they're going to an outside entity, a hospital or something to have it done, then we're not billing for that CAT scan. So that means it's okay for us to get credit for the ordering or reviewing that test. So again, we could talk about that offline. I'm happy to have further discussions on that. All right, so we're going to start with category. Oh, also before I move into the categories, I want to point out that each level, like limited is your low, and there's moderate, and there's high. Each of these have different requirements, and up here straightforward, there's nothing required for straightforward. For low limited, you must meet the requirements of at least one of the two below categories. And as you can see with low, it varies a little bit more. There's another, there's more to choose from. For moderate and high, for moderate, you must meet the requirements of at least one of these three categories. But for high, you must meet these requirements for two out of these three categories, which makes it a little bit more difficult to get a high medical decision or a high level for your data because it does require so much in order to be able to meet that level. So I'm going to dig into each of these categories and we'll go from there. So starting with category 1, this represents test documents or independent historian. So starting with review of prior external notes, you get 1 point per unique source. For example, reviewing records from both a PCP and maybe you reviewed a hospital stay, or maybe the patient was hospitalized over the weekend and you reviewed that hospital stay. You get 2 points there because one source was the PCP and the other source was the hospital records. A unique test is defined as any test that has been established that has an assigned CPT code, and each test can only be counted once. So do not count tests that you previously reviewed. So if you're looking back at test results over the past year, those probably already been counted, so you can't really count that. If they've been counted before, you can't count that toward the medical decision making of your visit. Also, review when you order a test. Part of ordering a test is reviewing those results too. So when you're ordering something and you review those results, you can't get credit for reviewing and ordering, because as you could see here, there's review of each test and ordering of each unique test. You can't, again, when you order a test, it's assumed you're also going to review those results. So you can't get credit 2 times for ordering and reviewing it. So you order a CBC and you review those results, that counts as 1 point for ordering, not both. And then that moves us to ordering of each unique test. Again, you get 1 point for each unique test ordered, but again, you can't count both ordering and reviewed for the same test. The last one under category 1 is assessment requiring an independent historian. And unfortunately, this does not include interpretation services, even though I feel like there's a lot of work there. Unfortunately, we're not able to count that. To get credit for this, the independent historian must be medically necessary and documented. So a couple examples: a caregiver providing history for a patient with dementia, or maybe a parent providing history for a young child. So we would look for that, document that whenever that's occurring, because there's more work that's being performed. Next is category 2, which represents independent interpretation of tests. This section applies to tests with a CPT code for which a formal interpretation and report is standard, such as diagnostic imaging. This section does not apply to laboratory services. And to get credit for independent interpretation, you must have personally reviewed the images or film, and you must document that clearly. So recommend using phrases such as, I personally reviewed the images, or I performed independent interpretation. That shows that you did more than just review a radiologist's their narrative interpretation. You're coming to your own interpretation. So there's a difference there. So definitely capture that verbiage if that's what type of work you're doing. And the last category is discussion with external healthcare professionals and other sources. This only applies to external physicians and other providers outside your organization, not someone within your organization, because you guys are extensions of each other. With that being said, yeah, it's only credited for external providers. And to get credit for this, the exchange requires an interactive exchange, not just a message or a chart note or communication through staff. And to get credit, your documentation must include the name of the provider and a brief summary of the discussion. Now, the next 2 slides basically goes over the same information that I've already covered verbally just now. I just added the information to slides for easy reference. Okay, the last column of the medical decision-making chart represents the risk of complications and or morbidity or mortality of patient management. And this last column encompasses decisions made during the encounter associated with the treatment and management of the patient. It also includes possible management options selected and those considered but not selected after shared decision making with the patient and our family. So maybe you recommended a prescription, the provider recommended a prescription, but the patient declined. You could still get credit for prescription drug management in that case, because it was still a recommended treatment. So straightforward examples up here: mental risk or morbidity from additional diagnostic tests. This is pretty much if there's no medical follow-up needed, or just observation, come back if needed kind of thing. Examples of low medical decision making include referrals, additional tests, following up, the follow-up visits, like come back in 3 months or 1 month. We could technically give you a low for that. But also over-the-counter medications, and this is going to be a discussion point as well. Over-the-counter medications that do not require prescriptive authority is not supportive of prescription drug management. Instead, this is a low risk. perfect example of this is Flonase. Flonase, the same milligram dosage that's available over the counter, is available also by prescription. A lot of patients could get it for minimal or no cost if they run it through their prescriptions. So the way they look at it, technically, it doesn't require a prescriptive authority because you're able to get it over the counter. And recently, ModMed, I know that ModMed users, there's been discussions on this. They recently released a statement where they're in line with this. So, and they're supposed to be changing their medical decision-making table within ModMed to accommodate this. So please reach out to me if you have any questions about that. Now moving on to moderate, one of the most common examples of moderate risk include prescription drug management. So again, this is for non-over-the-counter medications and not only consist of new prescriptions, but also refills. The documentation should include the name of the drug, dosage, and details to show that it's being managed. If you only document continued medications, this will not be supportive of prescription drug management from an outside auditor or payer. So in summary, document the drug name, dose, and frequency in which they should be taking it. Show some management to it, because again, if they just see continue same medicines, then they look at that as not as much work. So unfortunately, we have to follow their guidelines and stuff. So another risk element under moderate risk is social determinants of health. And this is one of the newer ones that they added this with the newer, like I think in 2023, maybe 2021. But you're able to get credit now if you have a patient that has an economic or social that's limiting their treatment. So any lack of food or housing insecurity, if it's impacting your patient from getting the treatment that they need or healing, then you may want to look at considering this area for your medical decision making. Maybe the patient can't get their prescription because of the cost or insurance won't cover it. So documenting that in the note, just know that that could give you a moderate whenever they're having some type of social determinants of health insecurity. Under high here, we have drug therapy requiring intensive monitoring for toxicity. There's not a lot of drugs that fall within this, and if you have questions, reach out to me. But examples include like Coumadin, lithium, cytotoxic chemotherapy. Those are some examples. And then other areas include decision regarding elective major surgery with patient-identified patient or procedural risk factors, which is similar verbiage that you'll see up in moderate, decision regarding elective major surgery, but the difference is moderate is without patient or procedural risk factors, and high is with identified patient or procedural risk factors. So this is very important. If you have a patient that maybe you're recommending surgery and maybe they have to get surgical clearance from the pulmonologist because they have COPD or underlying heart condition, clearly document that and paint the picture when you're making these decisions of, is this patient at a higher risk for this procedure because of those comorbidities? If so, then capture that so that it paints that picture, because the idea is let's minimize the scrutiny by making it as clear as you can within the documentation. Also under high, there's the decision regarding hospitalization. So let's say maybe the patient was in severe exacerbation and you're like, okay, we need to go to the hospital. You need to be admitted. That would be a high because it's regarding the decision regarding hospitalization. Okay, so now we went through all three of those main columns and we're going to pull it all together. I pulled an example of one. I figured we could go with this. So this particular patient came in because they were having sinus problems. This provider did a great job at painting a picture of not only what was going on with the patient and capturing a really good history of present illness, but they also gave a lot of the stuff that they had tried and failed in the past. And I just want to give, I don't even know which provider this is, but they deserve an applause. And the reason why is because there's sometimes these patients end up having needing advanced treatment later down the road, when you try and fail, the first line stuff, then when they get into the other advanced treatments, sometimes we have to paint a picture to the payer that it's medically necessary. So when we see stuff like this helps us if in case we need to do an appeal to show the medical necessity, because they really like seeing things that the patients tried and failed in previous treatment and stuff like that. So this is very helpful capturing this level of information. Anyway, this patient was having recurrent sinus problems, noted to be moderate in severity, listed those associated signs and symptoms. The sinus problem has been present for 2 years, so that tells me this is a chronic condition. Even provider also selected the right diagnosis of chronic sinusitis, but it's when we want it also captured in the medical note. So because we could just select a code, but the diagnosis the documentation has to support that code. So this definitely is supportive. It's showing it's a chronic sinusitis. It looks like they prescribed some over-the-counter sprays, but then they also prescribed some doxycycline and diflucan. They also ordered a CAT scan. So this is what we got. We have a moderate medical decision making in that case. There was a chronic condition that was not at goal, and treatment on that day was given and everything. So it was chronic. There was an exacerbation. So we've got a moderate there. We've got a low here, but I'm going to come back to that. And then we have prescription drug management because of the doxycycline and the diflucan. Going back to this, so I want to show you where I've got these 2 points from and how this could vary if we're billing for the CAT scan. Because if we're billing for that CAT scan, then we cannot give credit for that. So that would be 1 point instead of 2 in that area. So where did I get that other point from? When you look through this, you could tell that the provider was looking through a pulmonologist records, went into detail of a bunch of stuff. So I gave credit for one unique source. That's why it's important. Like if there were multiple sources, then to document, that. Otherwise, this looked like, everything was from that record of service, and that is considered one source. So that's how I got the 2. But again, this is more of a tiebreaker because we got a moderate here and we have a moderate here. So we officially have a moderate medical decision making. But again, if we're billing for that CAT scan, we wouldn't even give credit. This wouldn't even register on here because we wouldn't have any combination of 2. So this would be 0, but we would still have a moderate medical decision making because we have 2 of the 3 columns. Okay, so that was a lot of information in a short amount of time. I do want to point out that our next education session is July the 23rd. I will be sending an email out to the VPs and the practice admins so that they could share this with you and also get that meeting invitation out. We will be talking about mastering modifier 25, understanding when to bill an E&M service on the same day as a minor procedure or other service. Modifier 25 is one of the most highly scrutinized modifiers out there. OIG did a study years and years ago, and they estimated approximately like 35% of the claims that come through with modifier 25. And when I say modifier 25, the E&M visit has to have that modifier on there or else the claim will deny. But just because we have to make sure the circumstance and the situation is supportive of that. So that's where this session is going to be aimed at, is understanding when you should even bill that E&M visit on the same day as those procedures, because sometimes those minor procedures have some E&M components associated with that. And so if we bill an E&M and that, then we're technically overbilling. So we'll be going over what is inclusive of a minor procedure, what are those E&M components, and I'll provide a couple of little checklists for easy, to easy understand the topic and everything. So you could expect to get that email in the next couple, hopefully actually by the end of this week, I'll probably have that sent out. But yeah, I would love to have you guys join me for that session and we could dig into that modifier and talk about that further. All right, so I am going to turn it over to see if anyone has any questions. Any questions at the time? Let me check the chat.
You did say you were going to give us a copy of this, correct?
Yes, that is correct. I had some technical difficulties at the very beginning. Oh my goodness, it was awful. So I apologize for that. I did not record it because I was afraid to run into more technical issues. So I will be recording this. If not today, by tomorrow, I'll get a recorded session of this to you guys so that you can share to your providers that were not able to attend. But also, I'll have those little cheat sheets that I mentioned, the medical decision making tables, and I have a few things to send your way. So, as well as the presentation. So, and if your providers or any of you guys want to connect and discuss this, please reach out to me. I'm happy we could schedule a session and we could go over it further because I know there's definitely usually some questions and discussion points once I go over this material. So,
I do have a question. Would it be possible for you to send this to our providers? As I know if it came from you to listen to that it would mean more than if it came from us.
I mean, I certainly can. Yeah, I could reach out to them and send
I
it.
think that would be great.
Okay. Yeah. I'll get a list of the providers and send it to them. All right. Well, I really appreciate your patience. That was a rocky start, but I really appreciate your patience. Those who have worked with me know my motto is like, you got to love technology. So I was very appreciative of you bearing with me, but I'm here if you have any